folks. Thank you for all of you that have shown up so promptly. We want to make sure we get every moment out of Dr. Witkin while she's with us. So I want to welcome everybody. We are hosting one of our monthly provider seminars here at the Motherhood Center. On top of being an organization that aims to provide support and clinical care to new and expecting mothers that are experiencing what we call perinatal mood and anxiety disorders, we also really value the ability to educate providers like yourselves on things that have to do generally with PMADs and in more specific ways, and how PMADs apply to your work and your practice, and how we can all do our part to ensure that new and expecting mothers have the education that they need around perinatal mood and anxiety disorders, and most importantly, access to care and treatment so that they can feel better. So what we are going to do tonight is we are going to hear from Dr. Witkin, who is going to be giving us a presentation on pediatricians and PMADs, role, responsibility, and resources. We will hold until the end for Q&A, but if you have a burning question, feel free to put it in the Q&A, and perhaps we'll get to it in the moment, and if not, we will make every effort possible to get to it at the end. And we will be recording this evening's seminar, and once it's ready, we will be sending it out with a link for everyone in case you missed some of it, or you want to go back and watch it again, or you want to share it with a friend or a colleague. Lastly, I just wanted to announce at the Motherhood Center, for those of you who are just learning about us, or this is the first time that you've attended an event such as this, as I mentioned, we specialize in treating PMADs. We offer support groups to both pregnant and new moms that are struggling with the transition to motherhood. We offer outpatient therapy and medication management with reproductive psychiatrists that specialize in medication that's safe and effective to take during pregnancy and the postpartum period. And our very special offering that doesn't really exist anywhere else in the tri-state area is our day program. And this is for both pregnant and postpartum women that are having a really hard time caring for themselves and or the baby, and have moderate to severe perinatal mood and anxiety disorder symptoms. And while I am amidst many providers here with us this evening, I just wanted to let people know that we do have a couple of openings in our day program. So if you are working with a patient that might benefit, please reach out to the Motherhood Center, and we will do what we can to connect that new or expecting mom to care. So without further ado, it is my pleasure to introduce to you Dr. Ariana Witkin. Dr. Witkin is a pediatrician, postpartum coach, and motherhood mentor. She started coaching after the birth of her daughter and experiencing firsthand the lack of coordinated care and support for new mothers. When she isn't educating, empowering, and holding space for new mothers, you can find her examining Massachusetts' newest and cutest residents in her local community hospital, chasing after her sassy toddler, spinning on her Peloton, or stargazing on the deck with her husband. She's a board-certified pediatrician and completed her pediatric residency at University of Washington, Seattle Children's Hospital. She's contributed to Glamour, Very Well, Family and Business Insider, amongst others. You can stay up to date with her latest news and catch a glimpse of her baby girl by following her journey on IG at Ask Ariana, Dr. Ariana. And to learn more and for free resources, you can visit her website at arianawitkin.com. And at the very end, we'll have a slide, I believe, that provides all of that contact information for you. So without further ado, again, Dr. Witkin, thank you so much for being here with us. I'm going to turn it over to you.
Thank you so much, Paige. I'm so honored to be here with all of you and to be giving this presentation. Welcome to all of you. Thank you for being here. So as Paige said, today we're going to talk about pediatricians and PMADs, our role, our responsibility, and resources. So first, a little bit about me. As Paige said, I'm Dr. Ariana Witkin. I'm a board-certified pediatrician. I currently work as a neonatal hospitalist in a level 1 nursery. So I see well newborns and their families right after they're born until they're discharged home. I work in a community hospital in the Boston area where I live. My medical degree is from Mount Sinai in New York City, and I completed my pediatric training at University of Washington, Seattle Children's Hospital. Additionally, as you heard a little bit about, I run a coaching and consulting company that aims to empower pregnant and postpartum women with evidence-based education and support throughout the perinatal period. I also enjoy being involved in advocacy work and writing, and I'm a mother myself. I have a daughter who is almost 3 years old. Okay, so why are we here? We're here because PMADs, perinatal mood and anxiety disorders, are a major problem. And I would go as far as to say a public health crisis. There are roughly 4 million live births that occur in the United States each year, which equates to almost 600,000 women who aren't receiving adequate treatment for PMADs. And that's likely underreported, right? So the number is likely larger than that. Postpartum Support International estimates that about 15 to 20% of women will experience a PMAD, but there have been some more recent studies, particularly during the past year and a half during the pandemic, looking at the rates of postpartum anxiety and depression. And those estimates are closer to 70%, which is a huge number. Again, public health emergency. To look at it another way, maternal suicide far exceeds postpartum hemorrhage and postpartum hypertension as causes of maternal mortality. Postpartum mood and anxiety disorders is the most frequent obstetric complication, again, far exceeding hypertension and hemorrhage. So maybe you feel like, yeah, that's horrible, and I'm a pediatric care provider, right? Why should I care about this? What am I going to do about this? You're here, so hopefully you already care at least a little bit about this, but that's really what we're going to dive deeper into today. Because really at its core, our job as pediatric providers is to care for children. I know that's a simple way of saying it, but that's really what it boils down to. And we know that children don't exist in a vacuum, right? So for children, the most important thing, the biggest protective factor, is having a caring adult, someone who is well-adjusted, well-supported, so they're able to provide all the emotional, physical caretaking required of children, right? Which is a lot. We know from studies looking at social determinants of health and adverse childhood experiences that even in the face of structural inequities, right, like poverty, homelessness, food insecurity, which are all obviously major issues that affect the care of children that we care for as well, we know that in spite of those things, the presence of a caring adult is protective against adverse health outcomes in childhood and really beyond in the long term as well. So why are PMADs undertreated? It really comes down to two things. The first is that they're underdiagnosed, so the lack of awareness and lack of screening. And the second is inadequate treatment options available, right? Like it's really hard to find a mental health provider. Okay, so for our presentation today, we're really going to focus here on this first part, on the underdiagnosis of PMADs and how we pediatric providers can work to make effective change in this space. The main strategy that I'll be talking about today is screening. A growing number of organizations, including ACOG, which is the American College of Obstetrics and Gynecology, the AMA, the American Medical Association, and the United States Preventive Service Task Force, recommend mandatory depression screening of pregnant and postpartum women, as well as the Academy of Pediatrics, the APA, which actually has recommended mandatory screening of pregnant and postpartum women since 2010, so over 10 years. So our objectives for today, we're going to start with some basic definitions just to make sure we're all on the same page in terms of what we mean when I say pediatrician and PMAD. We're going to review a case of a postpartum client of mine, and then we're going to dive into our role and our responsibility and get super practical, tactical, and just really specific in terms of interventions that we can implement. Lastly, I'll leave you with some resources for learning more on this topic. Definitions. So when I say pediatrician today, I'm talking about any pediatric care provider, anyone who cares for newborns. So whether you're a physician, a nurse, a PA, a social worker, a pelvic floor physical therapist, a lactation consultant, right? I'm talking to you. If you work with mothers and newborns, this is applicable for you. Postpartum mood and anxiety disorder, PMAD. I think we've defined that already several times, but I just wanted to remind people here that we're not just talking about postpartum depression. PMADs come in many flavors, from depression and anxiety to OCD and PTSD to more rarely psychosis. As a reminder, you can be diagnosed with a PMAD during pregnancy, so before you actually give birth, and then in the first 12 months postpartum as well. Also, for the purposes of our presentation today, I'm going to use the term mother to describe the gestational parents and the primary caregiver. It's important to note that, of course, non-gestational caregivers and parents can also be affected by PMADs, and they also require screening and diagnosis and may require treatment, although that's out of the scope of what I'm going to talk about today. I'm going to read this quote. What basically everyone around me but me knew up until December was this: I have postpartum depression. How can I feel this way when everything is so great? And I put this quote in here from Chrissy Teigen before our case, just because I think it so well captures what many women feel, which is that they should be happy, right? Society tells pregnant women and new mothers that they're supposed to be overjoyed, consumed with love for their new baby, except sometimes they don't feel like that, right? And then they think something is wrong with them. So I really thought that this captured that sentiment quite well. Okay, so diving into our case. So this is a real case of a woman who was in a postpartum support group that I ran a few months ago. She is a 31-year-old G1, P1, so first pregnancy, first baby, status post of vacuum assisted vaginal delivery at 38 weeks and 2 days, so full-term pregnancy, presenting to her OBGYN for a 2-week postpartum mental health visit. Just for some background, she wasn't supposed to be seen by her OB until her 6-week follow-up, but she called to say that she had been crying daily, feeling exhausted, overwhelmed, so her provider scheduled her a 2-week visit postpartum. In terms of her past medical and past surgical history, it's not contributory. Mental health history, she has a history of anxiety. She was on escitalopram for a short amount of time, about a year, and then self-discontinued when she decided she wanted to get pregnant. She lives with her husband and her baby. She works as a consultant, although she's on maternity leave now. And in terms of the baby's past medical history, the baby did well after birth, was in the well baby nursery, and stayed in the hospital 1 extra day for phototherapy for hyperbilirubinemia, the treatment for jaundice. All right, so she gets to her appointment. She reiterates to her OB basically what I just told you. She's been crying, she feels overwhelmed, etc. So the provider asks social work to see the patient in the office. She's then screened by social work, not with a validated screening tool. She was just asked some questions by the social worker. And in one of those questions, she's asked if she has any thoughts of hurting herself or her baby, to which she says no. The appointment ends. The social worker tells her that she can go on Psychology Today and look for a therapist, or just wait to see if her feelings pass because it might just be the baby blues, which is normal, and the patient leaves. She feels like because she doesn't want to harm herself or her baby, that she must not have a PMAD. There must not be help for her kind of particular brand of feeling, and that she's not really bad enough to need any intervention. She definitely feels like she does not have the time or the energy to research therapists online, so she doesn't reach out for help further, and she continues suffering really alone. Now let's imagine, this part of the case did not happen, but let's imagine that the same week she goes to her pediatrician for a 2-week weight check. So as the pediatrician or the pediatric care provider, you may only know the baby's past medical history, although maybe you know the social history. You might not know mom's mental health history unless you ask. Maybe it's part of your standard history and physical, which would be awesome. So imagine that the pediatrician administers a validated PMAD screening tool and that this mother screens positive. This represents an opportunity for intervention and for offering resources, right? That really was a missed opportunity at her OB visit. No validated screening tool was administered, no referral was made. This particular scenario of women seeing their providers and not really having any resources is far too common, as is women not being seen postpartum until 6 weeks or not being seen at all. Postpartum visits dramatically decreased during the pandemic, and many of them also became virtual. So you as the pediatric provider, might be the only provider seeing this mother-infant dyad in person for literally months, right? Which again, really represents an opportunity for you to be the one to intervene. Okay, so this graphic shows the average number of visits that a pregnant person has with their provider during pregnancy and postpartum, as well as the average number of pediatric visits that we have in the first year. The current ACOG recommended prenatal visit schedule for first pregnancies that are uncomplicated is 1 visit every 4 weeks until 28 weeks, then every 2 weeks until 36 weeks, and then weekly until delivery. So that's roughly 11 to 14 visits during pregnancy, depending on when care is first initiated, which is a lot, right? 11 to 14 visits in a 10-month period. That's a lot. Postpartum, ACOG recommends 1 visit, just 1, at 6 weeks. Some providers will also do a 2-week visit, kind of depending on the presence or not of complications during pregnancy and delivery, which includes mental health concerns as well. Conversely, pediatricians, so the AP recommends 7 visits in the first year, 1 at 3 to 5 days, 1 month, 2 months, 4 months, 6 months, 9 months, and a year. Most providers will also do a 2-week visit for really a weight check the infant's weight, check on feeding. And some providers might also do a prenatal visit, like a meet and greet for parents to allow prospective families to see the practice, meet the provider, ask questions. So that means we, the pediatricians, interface with the mother way more than her provider does postpartum, right? Once or twice looking at this versus upwards of 8 encounters, which means that, again, we have many more opportunities, like 8 times more opportunities for screening and for potential intervention like referral to mental health services. You might be thinking, well, OBs and midwives see their patients so many times during pregnancy. Can't they talk about PMADs then? Can't they make a plan for referral just in case, right? And if you're thinking that, I don't disagree with you exactly, you're not wrong. However, the focus of antepartum visits really does tend to be on pregnancy and growing a healthy baby, right? They also really tend to focus on birth, the birth team, the pain management. They're really not focused on postpartum. We can argue about whether or not they should be, but in practicality, they're usually not. I often say planning for birth and not for postpartum is like planning for your wedding and not the marriage, right? We tend to treat the birth as the main event in society, when really it's everything that comes after that, right? That's really the main event. So for us, pediatricians, it's really us that has the opportunity, if nothing else, by sheer number of encounters alone, to screen for PMADs. Despite this abundant opportunity, a 2013 periodic survey of AAP members found that less than half of pediatricians were screening mothers for depression. Less than half. We have our work cut out for us, right? We have work to do. We have room to improve. Which really brings us to, what is our role as a pediatrician, right? That's really what it comes down to. Frankly, is it our job to even be screening for PMADs? We have a lot to do caring for children. Is this really something that we should be thinking about and including as a regular part of our practice? Obviously, I think the answer is yes, and I'm going to tell you why. So our job, yes, is to care for the comprehensive needs of the child, diagnose disease, assess developmental concerns, provide anticipatory and safety guidance to families, right? And I would argue it's also to care for the mother-infant dyad. and help families build a postpartum care team, right? Because this is going to have a huge impact on the child that is our patient. The term fourth trimester, which refers to the 12 weeks immediate postpartum, actually was coined by a pediatrician. It was coined by Dr. Harvey Karp. You probably know him as the inventor of the SNU. He also wrote the book, The Happiest Baby on the Block. He's known for his techniques for calming babies and soothing. So he invented this term, fourth trimester, to describe the infant experience in the first 12 weeks after being born. But it's also really relevant to the mother who's going through her own massive transformation, this huge identity shift in the first 12 weeks and really beyond, right? Postpartum. I like to say once you've had a baby, you're postpartum for life. So yes, it is the job of the pediatrician to care for the child, right? That's our patient. And we're not seeing our patients in isolation. We see them and know them and treat them within the context of their environment and family and community, which in the case of the infant is their primary caregiver, often a mother. So as we touched on earlier, the most important thing for a baby is to have a well-adjusted, well-supported mother or primary caregiver. So I would say our role is to understand fourth trimester changes of both the infant and the mother, right? I'm not talking about needing to understand the postpartum DVT risk, right? The blood clot risk or the risk for high blood pressure, but mental health risk I think is really important. And also to help build a postpartum care team for the families with which we're working. So this excerpt is from a policy statement from the AAP. It was published in Pediatrics in 2005, called the Pediatrician's Role in Community Pediatrics. It says a recognition that family, educational, social, cultural, spiritual, economic, environmental, and political forces act favorably or unfavorably, but always significantly on the health and functioning of children. So again, this policy statement just really speaks to the advocacy work that's inherent to community pediatrics and goes on to say that pediatricians should work collaboratively with public health departments to identify, decrease barriers to the health and well-being of children in the communities that they serve. So I take that to mean in terms of our topic today, right, that we should be working in an interdisciplinary way, right, with OBs, midwives, psychiatrists, psychologists, therapists, to have a referral system, as this is going to affect the well-being of the children who we serve. So we want to familiarize ourselves with the resources that are available in our own communities. So diving into this a bit deeper, how does maternal mental health affect infant mental health, right? That's really what we're talking about. How does having a mother with a PMAD potentially affect the well-being of children, of our patients, of the people who we're working with? So in general, studies show that PMADs lead to inappropriate medical treatment of the infant, can lead to discontinuation of breastfeeding, family dysfunction, and an increased risk of abuse and neglect. Not to mention, also has been shown to increase costs of medical care, as mothers with PMADs tend to overuse healthcare and emergency facilities. Often they present to the emergency room, their children often present with somatic complaints. An article published in Pediatrics again in 2019 that was called Incorporating Recognition and Management of Perinatal Depression into Pediatric Practice. This article really discussed how PMADs adversely affect the critical early period of infant brain development. For the most part, this article was looking at postpartum depression. But they found that research during this period, right, of early brain development, toxic stress, adverse childhood experiences has demonstrated physiological effects of the infant's environment on health, development, and learning, both in the short term and in the long term as well. Specifically, we've seen an infant that is raised in an environment of significant maternal depression is at risk for toxic stress and its consequences. And when I say toxic stress, I mean an unhealthy, prolonged activation of the stress response that is not being buffered by a caregiver, which puts infants at risk for impaired social interaction, delays in language, cognitive, and social emotional development. In terms of longer term sequelae, we've also seen that maternal depression in infancy is predictive of cortisol levels in preschoolers, right? So several years later, and that these changes are linked with anxiety, social wariness, and withdrawal. Another study that was done by the CDC cites PPD as one of the most common adverse childhood experiences that are associated with the costliest adverse adult health outcomes. So again, another long-term effect. In terms of short-term, studies have shown that the consequences of untreated maternal postpartum depression include failure to implement injury prevention components of anticipatory guidance that we do during our visits, like car seat safety, failure to implement preventive health practices like back to sleep, and difficulty managing chronic health conditions like asthma. So if we know that perinatal depression and PMADs are the most common obstetric complication in the United States, and that PMADs are an example of an adverse childhood experience with long-term adverse health outcomes potentially, excuse me, and that PMADs can be treated very effectively, thus buffering stress on the infant, it seems only natural that we pediatricians should be screening patients during visits, and really that we have an obligation to do so. So what is my proposed solution to the under-recognition and treatment of PMADs? Screening mothers for PMADs by primary care pediatricians, pediatric providers, and creating a system of care that utilizes referrals and community resources. Okay, so how do we start to think about this? I've hopefully now convinced you why pediatric providers should be screening for PMAD. So let's move into the how. So I'm going to talk about the EPDS, which is the Edinburgh Postnatal Depression Scale. Many of you may have heard of this, but it's the most frequently used screening tool, both in the research setting and clinical practice. Really, that's for several reasons. It's been translated into 50 languages, so it's widely accessible to a large, diverse population. It's only 10 questions, and they're health literacy appropriate. So it's short. Again, it's accessible. It takes less than 5 minutes to complete. It also includes anxiety symptoms, which can be a prominent feature of PMAD. Some downsides of the EPDS, of course, it doesn't capture everyone with a PMAD. It also doesn't specifically ask about constitutional symptoms of depression, like changes in sleep, which can definitely be a prominent feature of PMADs, particularly postpartum. So this is the EPDS here. It's the whole tool. Again, you can see it's 10 questions, pretty short. Each question is scored 0 to 3. The questions without an asterisk, so 1, 2, and 4, are scored 0 to 3, the top box being 0, the bottom box being 3. The other questions are scored 3 to 0, so the top box is for 3 points, the bottom box is 0 points. It's generally accepted that a score of 10 or more is positive. And when I say positive, I mean not diagnostic, but indicative that this person needs a referral for further evaluation and potentially treatment. You'll notice that question 10 asks about self-harm. Always, always, always important to look at this question, right, regardless of the overall score. Of course, if this question is positive, immediate action is indicated, such as referral to emergency services. So when and how often should this screen be used? We're going to talk more about that in a bit. For now, I just want to say that ACOG recommends screening once during the perinatal period. Remember, we said also some women never make it to their postpartum appointment, but they recommend screening once, which in my opinion is not nearly enough. So of course, if we screened more often, we would pick up more women who were positive and who potentially needed further evaluation and treatment. So this is from ACOG's guidelines for perinatal care. These are known risk factors for perinatal depression. I'm showing you this because breastfeeding problems, right, is shown here as a risk factor for PPD. And as many of you, I'm sure, are all too familiar, feeding issues, weight concerns are one of the #1 reasons for pediatrician visits in the first few weeks postpartum. So again, one of the most common issues we as pediatric providers see in newborns is a risk factor for PMAD, yet another reason why we should be screening. Additional risk factors that are not on this list that we're likely to encounter include young maternal age, difficult infant temperament, like a baby with colic, and minority, immigrant, and refugee populations. I mentioned these risk factors and just to give you a sense of who in your practice might be at higher risk. I still recommend universal screening, right? Regardless of risk factor, we don't want to selectively screen based on risk factor to avoid implicit bias. All right, so on to more how. Now you know why we should be screening, you know how to screen, but what about all the practical concerns that you're probably thinking right now? Some of the reasons I hear from providers about why they don't screen is that there's not enough time. Some of us have 10-minute visits. You have to prioritize a physical exam, baby care. There might not be enough medical staff. Maybe you're a sole practitioner. Maybe there aren't enough medical assistants or nurses to help administer or score the screen. Maybe you're not getting paid for it. And at the end of the day, pediatric practices are a business. Many of us are compensated based on the number of patients we see and the amount of money we bring in, as well as a fear that someone will inevitably screen positive, right? If you do this enough, you're going to get a positive screen. And then what? What are you supposed to do with that? So let's talk about these barriers and just look at them one by one in a really practical way. So time people can shrink. Let's talk about that first. So the screen could be given in a number of ways. You could give it to the mom at check-in if you have a receptionist or someone checking them in. They could fill it out in the waiting room, give it to a medical assistant during vitals. It could be scored. Results could be given to you and put in the medical record before you even see the patient. You could consider having an electronic version of the screen. Like if your practice has MyChart or a patient portal, send it to patients prior to their visit. Again, could be scored ahead of time, reported to you. If your practice is lucky enough to have like care coordinator or a social worker, this could fall under the realm of something they do as well. I do want to acknowledge the realities of practicing in our Western fee-for-service healthcare system, right, which really does put pressure on providers to see many patients in a short amount of time. I know, at least for me, a 10-minute visit does not bring out my best self, and I know that this is a reality for a lot of us. And for me, this just really highlights the importance of advocating for change on a policy level in terms of healthcare coverage and reimbursement. But for now, to acknowledge the system that we are in, let's talk for a second about billing. So how are you going to get paid for this? Because you should get paid for this. So the AAP, again, recognizes that PMAD screens are a measure of risk in the infant's environment, and therefore billing is appropriate at the infant's visit, even though the infant is your patient. So the code to remember is shown here on the slide, 96161. There's the name of it up there. The requirements to report this code is that practice expense is incurred, right? So such as nurse time, MA time, something like that. That you use a standardized instrument. So if you use the EPTS, you're good there. The instrument is scoreable. Again, EPTS, you're all set. And that the results are documented in the medical record. So create a dot phrase, right? Patient's mother was screened for postpartum mood and anxiety disorders using the EPTS. Score was X. Put that in your note and you are good. One caveat I'll mention, this might vary depending on what state you're in or who the payer is. So just make sure to check with your practice manager. But for the most part, this is the code that you're going to want to be using. You can also always use time-based codes or complexity-based codes to bill as well. All right, so what about dealing with the outcome? What do you do if someone screens positive? All right, so super concretely, these are things that you can say in the moment. This is common. You are not alone. This is not your fault. PMADs are a medical problem with treatment, right? Your job as the provider is to provide the container in which people feel safe enough to share. We want to be empathetic and effective in a short amount of time because that's usually what we have. So I created this framework to help you kind of set the stage for screening and to help set you up for next steps if someone does screen positive. So to start, we want to set expectations. You're here for a weight check, a newborn exam, but I like to take this time to provide maternal mental health resources as well, right? So you're saying to the patient, we're not just going to be talking about about your baby. We're also going to be talking about you. Normalize. PMADs are the most common postpartum complication. They are treatable and nobody's fault. So again, right, at least 20% of women, likely many more, experience that. So if this is you, you're not alone. I don't think you're a bad mother. Don't assume. Having a baby can be amazing and wonderful and also overwhelming and exhausting. How have you been feeling? So we want to avoid assuming, right? We want to avoid saying things like, oh, you must be so in love with your baby, right? Instead, we want to ask open-ended questions. When you ask this question, you might get someone that says fine, you might get someone that bursts into tears. Either way, you're setting the stage that you genuinely care for how this person is doing. And then lastly, screen. So we use a standardized questionnaire to screen for PMADs in all postpartum women. This test does not always capture everyone who is suffering. If you would like mental health resources, please let me know. There's help available. The other thing I just want to mention is a concern I sometimes hear from parents, which is that they're concerned that if they tell their pediatricians that they are suffering, that their baby might get taken away from them, or that we might just think that they're not a good mom and not a good parent. So it's really, really important to be clear with families about what your duty is as a mandated reporter, right? So you're not going to call the Department of Child and Family Services if someone tells you that when they walk down the stairs, they're worried they're going to drop their baby and their baby will die. Or when they cross the street with the stroller, they're worried they might let go and the baby will go into oncoming traffic, right? So it might sound silly, but this is a really common concern among parents. So it can really just be a good thing to address head on. Okay, other things you can say and cannot be said enough. Feel free to screenshot this. This stage is temporary. This is not your fault. You're doing a great job. You are the expert in your body and your baby. Taking care of a baby is a full-time job. You don't have to do this alone. All right, so you screen, you know what to say, but then what do you do? The number one thing to do is refer. Get to know what resources are available in your community. In some places, there's a mental health line that providers can call to get referrals for patients in need. If you're in the tri-state area, you have the Motherhood Center, which is amazing. Postpartum Support International is a great resource in general, as is the person's provider. If you're not sure where to start, starting with the person's pregnancy provider is generally a good person to refer them back to. Try to provide one resource to the patient in your office so they can walk away with something concrete that day. Again, Postpartum Support International, which is postpartum.net, is a great one. You can also try to connect them with another patient with their permission, obviously. But connecting with someone else who has suffered from a PMAD, right, knowing that you're not alone with your feelings can be enormously supportive, especially while you're waiting for a mental health provider or referral to come through. At the very least, if you do nothing else, make sure you schedule a follow-up with that dyad, with that mother and infant, to check on the mother's symptoms and see if the referrals that you've placed have come through. So when and how often should you screen? Getting back to that question that we asked a bit earlier. So as I mentioned, ACOG recommends screening patients once, which is not nearly enough. PSI, Postpartum Support International, recommends screening pregnant women 3 times during pregnancy and then again at the 6-week visit. They also recommend that pediatricians screen at 3, 9, and 12 months postpartum. The American Academy of Pediatrics, again, that article I mentioned earlier, recommended pediatricians screen for PMADs at the 1, 2, 4, and 6 month well-child check, so 4 times in the first year. There's no kind of one right answer, at least that's based on evidence that I could find in terms of how often and when you should screen. I think the important thing is to screen as often as you can in that first year. I would say 3 times at a minimum. So what you see here is really just a sample timeline of one way that you could implement screening, but it might look different for you. So for example, if you do have a meet and greet, if you meet with the family prenatally, there's a great opportunity to talk about PMADs and to administer the EPDS for the first time. That gives you a baseline, sets up the expectation with the family that this is something you'll be doing at visits. You can ask them about a mental health history. Such a great opportunity if that's something your practice offers. At the 3 to 5 day visit, not necessarily a time to screen again, but a great time to talk about the baby blues, maybe review PMAD warning signs. At the 2-week visit, again, would probably screen again. This is the end of the baby blues windows. If someone has symptoms lasting past 2 weeks, they're now in the PMAD realm, so a good time to screen. Ideally, again, women are seeing their own providers for a 6-week postpartum visit, not always happening, but ideally being screened again. So then maybe you screen again at the 2-month well child check and the 6-month well child check, or the 4-month and the 1 year, right? Just sometime between 2 and 12 months, you want to screen again, ideally twice. Can also be super helpful to post material around your office or your practice space, again, to help with that normalizing piece, right? So maybe someone doesn't quite feel comfortable disclosing to you or doesn't feel comfortable answering the screen honestly, but having things like this around your office can help people know that you're a safe provider to talk to. You can post resources there as well. So this is actually from a colleague of mine, Dr. Katrina Mitchell. She's a board certified general surgeon. She's a breast oncologist. She is also a lactation consultant in IBCLC. She has a practice in breastfeeding medicine. And this is a flyer that she posts in her waiting room and bathroom. And I just thought it was so great, right? Normalizing all of these thoughts that women have, and then resources on who they can contact for help if they don't feel comfortable disclosing directly to her. Okay, so that was a ton of information, I know, in a short amount of time. So wanted to give you some resources about where you could go to learn more. The Motherhood Center, of course, an amazing resource. Postpartum Support International. ACOG, as I mentioned, has a postpartum toolkit that can be quite useful. The AP has some resources, and the Postpartum Stress Center as well. You can also feel free to contact me if you have questions. My email is on this slide. Thank you all so much for being here and for all that you do for mothers and children. And I'd be happy to take a few questions.
Thank you so much, Dr. Witkin. Just want to encourage everybody, you can either put a question in the Q&A. I don't know if this particular Zoom function allows people to speak, but please do either in the Q&A or chat. Oh, I see. Go ahead, Nicole.
Hi, so I am a social worker, and I was wondering, what resources were out there. Also, just like very interested at this presentation and definitely want to be able to help clients the best that I can who are struggling with PMAD. So wanted to know how I can best support them.
You know what? I'm so sorry. You actually cut out. I had a little audio malfunction. Would you mind just repeating your question?
Yeah, absolutely. I said, I'm a therapist, and I really enjoyed this presentation. Thank you so much. Just wanted to know sort of like what resources were out there for me to educate myself on PMADs and also how I can best support my clients.
Yeah, totally. And Paige, feel free to jump in as well. So the Motherhood Center does have these monthly provider seminars on a wide range of topics. So that's a great way to learn about a variety of things that affect PMADs. I think in general, my favorite place to start would be postpartum.net, which is the Postpartum Support International website. They have a whole provider section with articles, and they run some seminars as well, if that's something that you're interested in doing continuing education about. Okay,
thank you.
And you had mentioned, Dr. Witkin, one of our favorite resources, also the Postpartum Stress Center. Well, she's a social worker, but I'm going to call her Dr. Karen Kleinman. She really is kind of the godmother of perinatal mood and anxiety disorders. She has been an expert in this field since the beginning of time. She's written a number of excellent books that are easy to read and really break down what it's like for a new or expecting mother or birthing parent to experience a PMAD, but also offers different books that target the provider population as well, different ways that we can integrate best practices in treating a new or expecting mother with a PMAD. And so she has a wealth of knowledge and information. And while I'm touting Karen Kleinman, something that you, the resource that you had shared, Dr. Witkin, about scary intrusive thoughts, which 80% of all new and expecting mothers have. She also wrote an excellent book called Good Moms Have Scary Thoughts. And we actually just gave a presentation earlier this week, my co-founder and I, to a large pediatric practice here in New York City, and suggested that they have a couple of those sitting in the waiting area. So that women who are waiting to see their doctor have some literature to look through. What's great about this particular book is that it's done with cartoons, and it's very digestible. So it's something you can kind of pick up and flip through. So yeah, some potential resources to get more information.
Thank you so much.
Go ahead, Joe. Shannon, I think you're managing the questions. Are you able to let Nicole ask a question?
Yep, she can unmute herself. And we had Jo, but I don't think I think she went away. So we can always have her back to talk when she's ready.
Thank you.
Oh, sorry, I wasn't meaning to raise my hand again. I'm sorry about that.
Oh, that's okay. While others are raising their hands, I can go ahead and pop over here to the Q&A and ask you some of these questions in the chat, Dr. Witkin. As a mental health provider, do you have any recommendations on engaging my local pediatricians more? They seem scared of PMADs.
That is a great question. Yes, so I think reaching out to them directly and offering yourself as a resource. I think part of the problem is, again, pediatricians could be concerned that if they screen and someone is positive, they're not sure what to do with that. So I think if you are a mental health provider that is open to referrals from a pediatric practice, for them, knowing that you are a resource in their community would be hugely helpful. So that's one way. Also offering to do like a little provider seminar, a little bit of education for the pediatricians in their practice, just explaining more about what PMADs are. I think could be super helpful, as well as I think there is a little bit of a lack of awareness and lack of knowledge in the pediatric community.
Thank you. And we have another question here from Colette. Any ideas where I could find a similar flyer to help normalize these thoughts?
Yeah, so actually so the flyer that I got permission to share, the flyer that I shared with you, if you email me, if you see my email on the slide, if you email me, or if anyone emails me, I'm happy to email you the PDF as well.
Great. And again, that book is another great way that, provides psychoeducation on scary intrusive thoughts, and does a great job normalizing them for women that are interested in learning more. While we're waiting for other questions, I just wanted to highlight, Dr. Witkin, something that's so unpredictable about PMADs, although there are many predictable things, right? Like women that we know who have a history of mental illness, either themselves individually or another member in their family, are at a greater risk of developing a PMAD in the perinatal period. That we also know that PMADs can develop at different periods throughout the perinatal process. So 50% of all perinatal women develop a PMAD during pregnancy, and the other 50% develop them in the postpartum period. But there's no hard and fast around when those symptoms develop, right? So there are some women who might be symptomatic a week after delivering. There are some women who might be symptomatic 3 months later, 6 months later, 9 months later. So when we talk about the necessity of regular screening, they might not have been symptomatic the first 6 months of the postpartum period. That's why it's so critical for us to screen throughout that first year. And I see we have another question here. How do you suggest supporting partners who don't understand the experience when the childbearing person developing and/or in the depths of a PMAD?
Yeah, that's a great question. And a difficult one. I certainly don't have the answer. I know the Motherhood Center does have programs for partners as well, as does Postpartum Support International. They have some resources for partners as well. Again, I think it's about psychoeducation to help partners understand kind of what is actually going on during that time. Paige, do you have anything to add?
Yeah, something that I scream from the rooftops as much as I possibly can, whether it's OBGYNs, pediatricians, really any provider who comes in contact with a new or expecting mother, or birthing parent, that we need to be providing the psychoeducation around PMADs, not only to new or expecting mom or birthing parent, but also to partners. As someone who experienced postpartum depression and anxiety firsthand, I use my own experience as a tool quite frequently, even as a licensed social worker who is trained to recognize mental illness in others. I was completely unable to recognize what was going on with myself. And in those situations when a new or expecting mom is really struggling, she's paralyzed, she's frozen. We cannot ask a lot of the time a new or expecting mother who's struggling to now go pick up the phone and do the research and find a provider. It is completely out of the capability and faculties of that woman who's in great distress. And this is why it is so important to educate partners, because they can so oftentimes serve as that life preserver, and they need to be a part of the conversation from the beginning. These are some things to notice. Does your wife or partner or girlfriend have a history of mental illness? He or she's at a greater risk, right? These are things you want to keep an eye on. Here's some resources that you can take advantage of in the event that, she starts to become symptomatic. And so the sooner we educate partner, the sooner he kind of buys into and understands the prevalence of PMADs. And then lastly, I would offer, again, Karen Kleiman, who has written so many wonderful books, wrote a book back in the 90s. If it was written today, it would not be called this because it is nowhere near as inclusive as it needs to be. It's called The Postpartum Husband. And it's such a great read because it's short and it provides information in bullets about what it is like for a new expecting mother to experience a PMAD, what a partner can do to support her as she's going through this challenging time. And it puts things so clearly so that partners can really wrap their head around what's going on.
Yeah, I love that. The other thing that I often do with clients during pregnancy is make what I call an SOS plan, which is kind of similar to what you said, but kind of lists out in a bullet form way warning signs, in general warning signs of PMADs, but also warning signs that are individualized, right? So we all have kind of different ways of coping. If you know that you're someone that when you're feeling sad or anxious, cries alone in the shower, right? That goes on the list, or whatever kind of your behaviors or actions are, so that your postpartum support team, may it be a partner, a doula, a parent, somebody else, knows what to look for, right? And you have kind of a set of criteria that says if the birthing partner is saying this or doing this or acting like this, we have all agreed ahead of time. That means that you as the partner or support person needs to reach out for help.
Right, exactly. I see another question here in the chat. Are you familiar with any grant or funding programs or creative avenues for community organizations focusing on maternal mental health? As a perinatal mental health provider, I volunteer with the home-based peer support program for families with babies up to 1 year old. As we dive into supporting families with regards to PMADs, we are exploring new funding options. Thanks for any guidance here.
So this is a struggle to find funding for this. So you're certainly not alone in your search for funding. I'm not actually aware of any current funding opportunities. Are you, Paige?
So for the first time in history, a few years back, the federal government initiated its first body of legislation that assigned $3 million to PMAD education, screening, and treatment initiatives that apply to different levels of government. I'm unfamiliar of how or if even that money has trickled down into states and localities. But it was something that was signed into law a few years back. Other than that, it might be worth checking in with, depending on where you're located, your state Department of Health, your local Department of Health here in New York City. The Department of Health and Mental Health is our local Department of Health, to see if there is any funding available. Sometimes private foundations have money that's not earmarked specifically for PMADs, but for mental health overall, and perhaps mental health of women. But I think, what this question really is asking, and the response is telling you, is that unfortunately, PMADs are not a priority in society, despite the fact that Dr. Witkin shared with us, they're the #1 complication associated with childbirth. They're the leading cause of maternal mortality in our country. And yet there are little to no resources dedicated to providing education, screening, and treatment for something that is so prevalent for this population. Any other questions from the audience? Here we have, do you ever associate bereaved parents dealing with perinatal loss with PMADs, or is that something entirely different? Is there protocol for pediatricians for support afterwards, or do they drop off? What are some ways we can support and or get involved in brainstorming ways to support families after loss together?
Yeah, so I think to answer kind of your question in pieces. So the first part, associating bereaved parents dealing with perinatal loss with PMADs. Again, I think it depends a little bit on the time course and the symptomatology. But I think you can certainly have both. You can have a grief reaction to perinatal loss and be affected by a PMAD. The two are not mutually exclusive. In terms of pediatrician support afterwards, so again, it depends a little bit on the timing of the perinatal loss. I'm a hospital-based provider. If we have a perinatal loss in the hospital, either at birth or shortly after birth in the few days, we do, at least at my institution, have a protocol for following up with the families if they want to engage with us. Sometimes they do not want to engage with the pediatric provider after a perinatal loss, but we are there to answer questions, provide support if the family is interested in that as well. In terms of ways that we can support or get involved after loss, so there definitely are support groups, just like there are PMAD support groups, there are support groups that are specific for perinatal loss that, again, I think the communal experience can be really helpful. And I think, again, as with, any sort of loss, grief can be very individualized. So having an open dialogue about kind of what's going to serve the family best can be really important, as opposed to having kind of a one-size-fits-all approach.
We do at the Motherhood Center offer actually 2 support groups around perinatal loss. One is for first trimester loss, and the other is for second and third trimester loss. And we get a lot of inquiries from women and their partners that are looking for grief and crisis counseling after perinatal loss at different intervals. And so if for some reason we can't capture that through one of our groups, we have many referrals that we make here in the New York City tri-state area for women to get that specialized level of care to be able to process that grief and develop some skills around how to manage it. Any other questions from our audience members? Well, we are ending right on time. I want to thank you so much, Dr. Witkin, for joining us today. We speak to pediatricians quite a bit here at the Motherhood Center, and I'm going to borrow much of what you said. I hope that's okay. There were some really brilliant points that you made. I hope everybody found this helpful. What we will be doing is sending around a link to the recording of this and any other supporting information. If Dr. Witkin is willing to share her presentation, or I'm going to send around a link of some of the things I mentioned, some of the books that I mentioned, so that you can access those. But thank you very much. And we do a provider seminar like this every month. So join our mailing list, visit our website, and you'll be able to stay on top of what's next. So thank you everybody for joining us, and have a great rest of the evening.